Thank you very much indeed, Christina. It's a great pleasure to talk. In fact, it was a beautiful granddaughter who was born in Chile when I was in Chile last. And it was a very anxious time for me, but it ended happily. So thank you very much for inviting me to give this talk. I've got no conflict of interest with regard to this presentation. I'm going to discuss in the future, I suppose my starting point is what are we doing badly now? And how are we going to change that in the future? And I think one of the things we're still doing badly is precision medicine. And I'm going to talk about phenotypes and endotypes because we're a long way behind airway diseases such as cystic fibrosis. I think certainly in the United Kingdom, we are not measuring. We're just making diagnoses on history. We've got to get a measurement culture into our bloodstreams. I'm going to discuss why asthma lung attacks, and I don't call them exacerbations, why they're serious, how we must do much better, and how we can do much better. And I know that Professor Saglani has talked a lot about the monoclonals. I'm going to enlarge on some of her observations and showing the scandalous gaps we have in our pediatric evidence base. We've got to do better. And again, one key message from this talk, in the future, we cannot allow our children to rely on evidence from adult studies. We've got to get the pediatric data. And I'm going to discuss something we never thought of before it happens, COVID, and how this will change the future delivery of care. So the future, getting up close and personal, first and foremost, asthma is a description, not a diagnosis. And this is emphasized by the fact that mepolizumab, now widely prescribed, could have been lost. So this was an early study, 15 MEPO patients, 8 placebo, a single dose was given, and the endpoint chosen was airway hyperresponsiveness. The eosinophils just dropped like a stone, and you can see here the blood eosinophil count. On the open circles are the placebo, the two solid lines are the MEPO. Eosinophils really hit the deck, but there was no change in airway responsiveness. In this panel, both MEPO doses are combined, no change in airway responsiveness. This was published in the Lancet, and very nearly MEPO was dropped. Fortunately, experienced investigators took it further and looked at a more appropriate group of patients. So here, this was in 16 steroid-resistant patients, from McMaster, the patients without an asthma attack, MEPO, the solid line, placebo, the dotted line, and you can see the asthma attacks are greatly reduced. And in the same issue, 61 patients with recurrent severe attacks, the cumulative number of attacks in the placebo group in blue is much greater than the MEPO group in orange. So MEPO was saved, but it could have been lost because we just did not think of asthma as a description, not a diagnosis. So let's get out from under the asthma umbrella. What could happen to an airway? Well, if an airway is in a bad place, has a noxious stimulus, there's very few things it can do. Just as if a kidney is damaged, it can put up the blood urea and creatinine and leak protein into the urine, but these are all non-specific. So for the airway, what can that do? Well, it can obstruct, and it can be fixed obstruction or variable obstruction, of which one causes bronchoconstriction. And the question is, does this patient have the treatable trait of bronchodilator responsiveness? And if it does, you prescribe beta-2 agonists. Is airway inflammation present? If so, is it beneficial? What type is it? Treatable trait 2, is there airway eosinophilia? If so, try inhaled corticosteroids. Don't if not. Is there chronic airway infection with or without impaired host defenses? Prescribe antibiotics. So asthma is an umbrella term. It's a clinical description of wheeze, dyspnea, chest tightness, sometimes excessive cough, just as anemia is an umbrella term for low hemoglobin, and arthritis for hot, red, painful joints. If you went to a rheumatologist and he said, you've got arthritis, go away, you'd be horrified. You'd expect better than that. You'd want to know, what arthritis is it? And so you should. So what about phenotypes and endotypes of asthma? What is a phenotype? Well, it's the set of observable characteristics in an organism resulting from the interaction of its genotype with the environment. And phenotyping, of course, must lead to useful action. And we talk about phenotypes like eosinophilic airway inflammation. But the airway phenotype of injury is very, very stereotypical, whatever the underlying cause, narrowing and inflammation, as I've shown. And the result is chronic non-specific treatments and random N of 1 trials. Now, let me stress something about the phenotype. We talked about interaction between the gene and the environment. Well, if the environment changes, the phenotype will too. And this is where that we need to differentiate phenotypes from endotypes. So here's a 10-year-old atopic boy with untreated wheeze. He's got eosinophilic asthma. He gets prescribed inhaled steroids and takes them. Inflammation disappears. He's got pulse inflammatory. He then gets exposed again to a big allergen load, and he becomes eosinophilic again. The allergens are removed. He gets rhinovirus infection. He's neutrophilic. He stops taking his inhaled steroids. He's eosinophilic, and then restarts back to pulse inflammatory. So phenotype will change over time. It's not a fixed characteristic. It's better than nothing, but we have to move beyond phenotypes. And indeed, Louise Fleming many years ago looked at the stability of inflammatory phenotypes in children. In this study, she had 55 severe asthmatics, of whom 42 produced more than one sample over a year. And she showed about a quarter of them were always eosinophilic. About 30% were always non-eosinophilic, but nearly half demonstrated both over the year, and similar results for mild to moderate asthma. And if you look at her sputum results here, the top panel is sputum eosinophils, the bottom panel sputum neutrophils, and you can see that unlike what is described in adults, the phenotype is all over the place. So what do we really want to know about? Well, we want to know about an endotype, which is a subtype of a condition defined by a distinct functional or pathobiological mechanism. And the result is pathway-targeted specific treatments. And the real exemplar, which I haven't got time to talk about, but we all know about, is cystic fibrosis, where they found the gene, they found subtypes of the gene, they developed specific molecules for specific subtypes really precisely. That is our target, and we're a long way from home. So personalized medicine, asthma is a description, not a diagnosis. Confronted with a child query asthma, ask, is this an airway disease at all? For the most part, now we can only ask ourselves, what is the phenotype? And thirdly, what is the context? Are there extrapulmonary comorbidities, social or environmental factors contributing, particularly adherence? We need to describe what's going on in the airway, fixed and variable obstruction, inflammation, infection. Don't treat what isn't present. If there's no airway eosinophilia, why would you give steroids? If somebody has a normal blood pressure, why would you give them antihypertensives? But be aware that phenotypes change over time. And the next step, for the young investigators, we've got to go to the endotypes of asthma and target specific treatments at them. So what about diagnosis of asthma in the 2020s? The measurement culture. 4 academic primary care centres, children aged 6 to 16 years, and they looked at that more than 10% were coded as asthma, 106 were uncoded but prescribed asthma meds. 308 of those coded asthma were not using asthma meds, and only 21% had an objective diagnosis of asthma. And you can see here, more than half of these patients you had no reason to believe that they actually had asthma. They were misdiagnosed. Now, if this is in an academic general practice, how bad must it be in a non-academic one? And again, we've relied now and in the past far too much on taking a history, relying on secondhand descriptions. So overdiagnosis of more than 50% of children leads to overtreatment and trivializing what is a killing disease. Few had an objective diagnosis. Academic primary care doing badly. And I challenge you, can you name a single other situation where children or indeed adults who can cooperate with investigations, simple investigations, are given a diagnosis and committed to medium to long-term treatment with no objective testing when such can easily be performed? This is a shocking scandal that we simply cannot tolerate in the future. So made to measure, when will we take measurements seriously? Measure, measure, measure. Does the child have a disease at all? And of course, knowing the limits of normality is terribly important. Is there positive evidence for an asthma diagnosis? I'll come to that in a moment. We know there's no gold standard test for asthma, but we can at least do some tests and look for confirmatory evidence. Or if we're not finding evidence, think, well, is this really asthma? Is there evidence for an alternative non-asthma diagnosis? So here, for example, in the flow volume curve, you can see a marked attenuation of the expiratory flow volume curve. This patient has a large airway obstruction, in this case by a vascular ring. You won't make that diagnosis unless you try to look for it. Evidence for asthma. At all ages, we should be attempting variable airflow obstruction, atopy, airway inflammation. Acute response to salbutamol if the peak flow is low or the child is wheezy. Acute bronchoconstriction or wheeze to a field exercise test. Peak flow variability for 2 weeks in the older child. Are they atopic? Is there positive history? Skin prick tests and specific IgE to relevant aeroallergens. Evidence of inflammation. Exhaled nitric oxide. Peripheral blood eosinophil count. In a special center, possibly induced sputum. But there are a lot of tests that can be done. And if you do these tests and they're all normal, you should be asking yourself, are these symptoms really due to asthma? And this was another study from Norway, really important, a questionnaire study. And they showed that in this over nearly 4,000 adolescents, the prevalence of exercise-induced bronchoconstriction was nearly 20%, and exercise-induced laryngeal obstruction nearly 6%. And a subsample underwent standard treadmill tests for both conditions. And what they showed was that a small number had exercise-induced bronchoconstriction, and a small number had exercise-induced laryngeal obstruction. Some had both, but nearly half who were complaining of breathlessness had neither of these conditions. Many were being filled up with inhalers. They were not particularly obese, but they were deconditioned. So before we give more and more inhaled medications, let's measure and find out what is the cause of the breathlessness. And just for those who haven't seen this, a swimmer who kept coming last, a 15-year-old girl, near Olympic standard. And she gets noisy breathing and respiratory distress towards the end of the races, not afterwards, towards the end, impairing her performance, doesn't respond to anything. A diagnostic test was performed, something that anybody can do. I'll hold the instrument up for you to see. It's a mobile phone. The diagnostic test was performed, and let's hope we get. So here she is swimming. Now listen, here she's got stridor. She's got stridor. She's got exercise-induced laryngeal obstruction. You can make a formal diagnosis of this in the laboratory by doing laryngoscopy during exercise. And you can even do that. This is Jim Hull with one of his PhD students swimming while she's having a laryngoscopy. But this will not respond to asthma treatment. So attacking asthma attacks, never events. They should be like a surgeon cutting off the wrong leg. They should not happen. If they happen, they're a disaster. So exacerbations, which they've been called out in the past, are relatively benign, a minor inconvenience, and fully reversible. But if you think lung attack, that's an emergency to be dealt with. There may be irretrievable damage, and we need a focused response. Why did this happen? How can we stop it happening again? It should be a red flag sentinel, something's gone badly wrong. Why do people get asthma attacks? Well, in this systematic review, we found 68 papers out of a huge number of records, and these were the findings. Red is if there's a big effect, and the bigger the circle, the more confident we are of it. And you can see the biggest thing is a previous attack. There are regional differences. In the USA, access to treatment is a factor. Beware previous attacks, symptoms, suboptimal treatment, including low pickup of inhaled steroids and high pickup of short-acting beta agonists. And this is data from Sammy Suisa from years ago. And he looked at the number of canisters of inhaled corticosteroids picked up per year. And that you can see you're more likely to die the fewer you pick up. And if you look, gain the number of canisters, ignore the phenotyrol data, the salbutamol data, the more canisters you pick up, the more likely you are to die. And the question is, should we actually be using the blue inhaler at all? And there's been a sea change in guidelines. So guidelines are a bit strange. Step one, a short-acting beta agonist, an inhaled steroid if you're using 3 times a week or some arbitrary number. Step 2 and above, you must use regular anti-inflammatories. You mustn't use long-acting beta agonists as a solo agent. That's the polar opposite of step 1 recommendations. And this is a meta-analysis of 4 randomized controlled trials, shamefully in patients 12 and over, not 11 and under, 8,000 subjects, and they compared at all levels of severity, combined budesonide formoterol as reliever therapy used as needed with regular inhaled steroids. And you can see the time to first severe exacerbation was better in the shared, in the combined group. The rate ratio for severe exacerbation ditto. There was a slightly worse asthma control test using the combined inhaler as reliever, but it was below the minimally clinically important difference. And the suggestion is that this may be the preferred option going forward, so we do not allow people to overdose on short-acting beta agonists because they're not prescribed. We have a little data in children. This is from Len Beccaria, African-American children aged 6 to 17, randomized either to standard provider-based medication or as needed combination of albuterol, short-acting, and beclomethasone. They used an inhaler dose counter, and the primary endpoint was actually asthma control. And you can see here, looking at asthma control, it really is pretty similar between the two groups, perhaps slightly better in the provider-based, the standard therapy. If you look here in the SEACT and the younger children, absolutely the same. But importantly, you are getting the same outcomes with taking far less inhaled steroids. And this was well received by families. Families like this treatment. So let's take asthma attacks seriously. Despite the fact we've got more and more guidelines and longer to read, people still die of asthma. We don't need guidelines. We need to learn lessons better and deal with it. Asthma attacks are a major red flag event. They are not a trivial inconvenience. They can and should be prevented. And if they're not prevented, we need to review the patient. What's gone wrong? How can we stop it going wrong again? And we must get combined formoterol budesonide reliever therapy evidence in the 4 to 11-year-olds. Why do we only have adult data? Mad about the monoclonals, and Professor Saglani has talked about these. Are biologicals the answer? And reviewing the literature over the past year, the new pediatric efficacy data is summarized here. It's an absolute scandal, the lack of efficacy data in the new anti-Th2 strategies. We have it for omalizumab, we don't for anywhere else. Here are the various biologicals that are available. Omalizumab, dupilumab, MiPo, reslizumab, benralizumab. What can we prescribe in children? Just 2 of them. Isn't that shocking? But the question we've got to ask ourselves is, are eosinophils all the bad guys? And in this study, they started from the premise that people with allergy or asthma were less likely to die in hospital infection. So they gave mice intratracheal Staph aureus. They looked at IL-33 pre-treatment because IL-33 induced type 2 inflammation. And they also looked in IL-5 knockout mice. And they showed that in these mice, IL-33 reduced airway eosinophilia, reduced IL-5, and lung injury mortality was reduced. So here you can see the IL-33 treated mice did much better, but the placebo mice and the IL-5 knockout mice, IL-33 treatment didn't work. So here's perhaps, I know mice aren't human beings, but there's at least some suggested evidence that mouse eosinophils are immunoprotective. What about COVID and the blood eosinophil count? I came across this paper when preparing for this talk. They did a retrospective review of COVID positive asthmatic adults. And quite a large number of patients who came to the emergency department were admitted. And those whose eosinophils were previously higher, their blood eos were previously higher, were less likely to be admitted. And those hospitalized patients with high eosinophils were less likely to die. So you can see in this panel, those whose highest eosinophil count in hospital was less than 150 were much less likely to survive than the blue, those who was 150 and above. Mechanism unknown, but at least these are challenging data. And are all anti-IL-5 strategies the same? I know Professor Saglani has talked about benralizumab. Benralizumab virtually obliterates sputum eosinophils. They just disappear. So if you look here, comparing on the left, ruzasvimab, mepolizumab, and benralizumab, you can see that benralizumab on the right more or less completely destroys sputum eosinophils, whereas there's still quite a number present in the ruzasvimab and mepolizumab data. And what about infection? Well, after starting benralizumab, the patients suffered more infections. Pre on the left, post on treatment on the right, more infections in benralizumab. Their asthma attacks that they were on benralizumab were non-eosinophilic and infections, and there were more infections on benra compared with the others. So you can see here the total number of infections, much more in benra. And if you look at those who in all three groups had the eosinophils wiped out, again, benralizumab is still associated with more infections. And this worries me when it comes to children. We need the data. It may be these agents work very well, but we've got to have the data. So where are we with monoclonals? There's a shameful lack of pediatric efficacy in safety studies. We rely on adult data, including predictive biomarkers. The adults predict response to their monoclonals on the peripheral blood eosinophil count. Well, these data recently from the ERJ, if you look at adults, yes, but from 18 onwards, the blood eosinophil count is pretty stable over the age range and doesn't go much higher than 300. But look to the left of the red line at children. Normal children may have eosinophil counts twice that of adults. So where does that leave us predicting response to biologicals? Potentially useful monoclonals are not available to us, such as dipilumab, and others which, and challengingly, there may be ones like anti-IL-13, which look like being discarded in adults. They're assumed not to work in children, but we don't know. We cannot assume that all eosinophils are the bad guys, and it is clear that too dramatic ablation may bring problems. We have no studies from countries with a high parasite burden, where again you'd worry about wiping out eosinophils. And these things are outrageously expensive, well beyond the purse of low and middle income countries. So finally, care after COVID, not back to the past. Well, the striking thing is asthma outcomes improved. So you can see the green in how asthma outcomes, emergency department visitors absolutely plummeted in the COVID era. And this is one of many studies to that effect. And we had to find ways of delivering care differently. There was fear of cross-infection during travel and at the hospital. Hospitals were afraid of COVID being introduced into a COVID-free zone. There's fear, is there going to be another COVID surge? Will there be a new epidemic virus? And we realized that much of what we took for granted as only being able to be done in the hospital can actually be done remotely, saving time and money. And I believe going forward, the default will remain that we will do it at home unless something can only be delivered in hospital. We'll be doing more and more home care. So how could this work? Well, height, weight, growth chart. Well, primary care is surely capable of doing that for us. What about a mobile phone app with an e-stethoscope? Wouldn't it be useful if I knew that when the patient's family was describing wheezing, I could actually have a tape recording of the wheeze? Home spirometry, exhaled nitric oxide with video supervision. And our technicians have been absolutely brilliant with spirometry. They do directly observed spirometry using video links to make sure they can coach the patient and get the technique right. We've talked about the Niox Mino, electronic adherence monitoring. We simply must do better than asking the patient, are you taking your treatment? There's no reason why we can't use remote directly observed therapy. And this is a study that from the Brompton MDT in severe therapy-resistant asthma and refractory difficult asthma. They got biologicals, normally given in hospital with 2 hours post-injection observation. In COVID, they set up a home administration program. At least the first 3 doses were given safely in hospital. Then they were allowed to do it at home. The nurses witnessed the injection in real time so they could coach the mothers, help them through if there were any problems. It was safe, it was liked by parents, and there was no evidence of impaired quality of care. So we're not going back to 2019. Telemedicine is here to stay. Families will not want crowded clinics. And indeed, will we need to do CF-style isolation clinics where patients come into a room and sit there rather than wait in the waiting area? How best do we use technology to monitor patients in their homes? What about safeguarding? And that's something that's been a real problem for us in the United Kingdom. All too easy to keep your battered child away from prying eyes by saying, I've got COVID, I'm self-isolating. There is a societal challenge. One of the things that may contribute to a good outcome is the low level of atmospheric pollution. Another is that lockdown prevented transmission of the standard respiratory viruses. Do we need to get out of the habit of dosing our kids with Calpol and sending them off to the nursery? Should we be taking them out of nursery more? How do we sustain behavioral change? Obesity, that's another big one that we need to worry about, because the obese did much, much worse. Remember, the better outcomes that I showed you in the American data were achieved not by expensive medications, but by behavioral change. So in summary and conclusions, what are my take-home messages from this talk? So asthma is a description of symptoms. By lumping all the asthmas together, we risk losing important treatments in the past. And if you say to somebody, or you think this child has got asthma, that's the start of a diagnostic journey, not the end of it. We've got to make measurements to support diagnoses, to understand the nature of airway disease, and use technology to monitor response to treatment. Just saying to the family, hi, how are you? How's your child? Is he okay? And how feeble is that in the 21st century? Asthma attacks we've got to take seriously, because as sure as God made little apples, if somebody's had an asthma attack, they're going to have another one unless something is done to change that round. And I believe asthma guidelines need to change, and that salbutamol should no longer be prescribed to school-age asthmatics. But we really do need to get the evidence. And we need to have a 21st century mindset, including in the delivery of care, how we deliver care, and above all, getting evidence in children. We cannot continue to rely on extrapolation from adult studies, letting the most vulnerable people be treated on the most meager evidence. We've got to do better. So I'd like to thank you for your attention. I'd like to thank funders, supporting centres, particularly children and their families, and the whole MDT. Thank you all for listening. And this little tot on the extreme left in the red stripy pajamas is my granddaughter, who was born 2 years ago when I was in Chile. Thank you very much indeed.